So my name's Charlotte Tucker. We both work for Gloucestershire Care Services. At the time that I started on the demand and capacity journey, I was in a service improvement role. I'm now managing operationally the services that I was modelling in the beginning, so it's been quite an interesting journey. I'm one of those strange people who is a clinician but a data geek at the same time, so I enjoy both.
Yep. So I'm Matthew O'Reilly. I'm Head of Strategic Business Intelligence at Gloucestershire Health and Care NHS Foundation Trust, and I've been working closely with Charlotte over the last year on our modelling journey.
Yeah, maybe longer. Okay, so I got asked about 18 months ago, is there sufficient workforce to meet the demand in relation to our MSK physiotherapy services that were significantly failing on their 8-week RTT. So I was in my service improvement role. I was asked to meet the team, come up with a nice action plan and trajectories, and all of the things that we've talked about today about people saying, well, it's our DNA rate, it's our sickness rate. They were all the answers that were given to me as the problem, to such an extent that we really believed that actually DNAs were probably the biggest problem that we had. And then I went on the Train the Trainer programme and learnt all about demand and capacity, and came back to the organisation and met Matthew, who had knowledge of demand and capacity modelling, and we started on our journey. So just to give you a bit of background, Gloucestershire is a really huge geographical area, so the community services that we deliver are delivered in lots of different localities, 7 localities around the county, and we're serving a population of about 650,000. And then in terms of the various services that we're going to talk about today that we've modelled, MSK Physio has lots of subspecialities underneath it, as does podiatry that we moved on to a little bit later. So this becomes relevant when we talk about how we did the modelling. And this is just to show you, like I'm sure you're aware that services don't just run in a nice linear pathway when we talk about pathway mapping and how we're going to understand demand and capacity. So this was kind of the spaghetti diagram of how we were trying to map capacity from referral in to first appointment and on to follow-ups. You want us to move that way a little bit? Okay, and this will become clearer a little bit later on as to why, but we'll get into that later.
So our modelling, we started off, like I think a lot of you, using the core model, and we moved on fairly quickly to using the advanced flow model for a number of reasons. Mainly that it enabled us to model new and follow-up capacity and demand in the same model, which reduced the amount of models we were having to maintain as we developed our range of models. And I think it gave us a better visualisation of, in particular, waiting lists and backlog clearance within that model. And as we move on through the slides, we'll also show you that we've started to use the aggregation module then in conjunction with the multiple flow models that we've developed within the subspecialties within the services, and also where we've modelled across localities. So, similar slide to I think we've seen from quite a few people today, the box at the bottom in particular with the cross way below the required capacity. So back to Charlotte's original question in terms of workforce and capacity, we came up with an answer, but we've titled this slide an answer but not the answer, because we were able to go back to our executive team quite quickly and give an overview of the position within the service. But once we started working more with our service leads and team leads, the questions then were very much around, well, which of our subspecialties have we got a gap, and what size is the gap, and within which of our localities that we deliver those services have we got a gap, or have we got too much capacity, which then led us to look at a very different scope of modelling, down to locality across our 7 localities and our 4 subspecialties. So we ended up with 11 different models and 3 different scenarios across those models of changing capacity based on new patient ratios across the whole staff group or across different bandings of staff within those groups, which we presented as a there's a table that you can see here which gave a huge amount of detail to have a really detailed evidence-based discussion with our clinicians, but it's not very pretty and it's not that easy to work with. So we then went on to start using the aggregation module, which you can see the same data presented in the previous table, but much more graphically, visually. You can see easily the X's for and showing the gap to the boxes. And this enabled us to have much more meaningful conversations with our clinicians in terms of presenting the output from those models. And again, just another view of the aggregation module in terms of seeing the solitary blue box where there was enough capacity compared to the ambers. Charlotte talked initially about the MSK physio service. We've gone on then to do more work with the podiatry service, and again this is looking at the aggregation module outputs across the different subspecialties within the service. What we've also looked at with all of our services that we've modelled is two different versions of models. One looking at the establishment, which this slide's showing, and the second slide looking at the in-post capacity, so that then when we're having discussions with our service leads, with our exec team and with our commissioners, we can see the gap that we've got. So there's two slides you can see as Charlotte's toggling between them. You can see the position where the X's are on the two slides. You can see them moving, but very visually. And I think though that's been an approach we took because we know there's a gap there, and it's just been about trying to describe that and give that evidence base.
And that's a bit about some of the capacity you can change and some you can't. If you've got vacant posts and national recruitment issues, then that's a whole different issue, and whether you need to look at things differently. So we then thought, so what? So we've got this data that shows a gap, but what are we going to do with that? So first of all, and I think it's already been covered today, but it's all that sense checking with the service that the answers you're coming out with are the things that they actually relate to and believe are correct. And then we were able to use that data for MSK services to hold a workshop and actually show people this is the problem that we're dealing with, some other data that we'll come on to in a minute about productivity, and just actually start talking about what do we need to do to address this problem, and then start a service improvement programme. It also enabled us to talk to our boards really about what's going on. So all they've seen are the RTT trajectory data every month and wanting improvement trajectories, but didn't really understand the narrative behind the problem. And by doing then that and them understanding it, we've been able to have sign-off for some quite radical changes as we've gone along. And then lastly, we've been able to present it to our commissioners, who then also have the same understanding of the problem and have been a bit more on board with different changes that we've wanted to make, and actually in some areas have actually agreed to kind of suspend our RTT reporting, understanding that the problem's bigger than we can currently solve.
So our learning to this stage and at this point has been that the outputs have been useful and kind of support the narrative in some cases. But we've been able to use the data and the modelling to really drive some meaningful change within some of the services that we've worked with. And because we've had that executive buy-in and that buy-in from our commissioners, it's a case that we said not just a nod and park in it. I've been involved in modelling before where you've completed models, you've shared them with a service, but there hasn't really been any action as a result of it. And what we're seeing now from this programme is a real sustained change and a buy-in to delivering that change. Yeah,
I think it was interesting when we sent out the first set of models, we got email replies that just said thank you. And it's like, no, this is the information for you. You now need to decide what you want to do with it. And I've talked to people in the room who, they've created their models, they're sending them out to services, and that's almost the job done, but it isn't the job done. It's just the beginning, and it's just the start of a conversation and a bigger piece of work.
So the next couple of slides are just a couple of examples of how we've worked up the presentation that we take to our executive team and our commissioners. So rather than sharing 11, 20, 30 different models. We've pulled that together into a really visual, easy to understand analysis that basically takes you through from referral to first appointment to follow-up appointment, but highlighting where some of the issues are. So within the MSK physio pathway, a waiting list of 2,800 is a sustainable list size of 2,000. Identifying the DNA rates compared to national averages, our cancellation rates, and some of the other rates and ratios that holds the attention and has got some real buy-in. There's nothing there that isn't in the models or isn't in the analysis we've done to support the modelling process. It's presented on one page, quite pretty, quite visually, but it's got a lot of buy-in.
Yeah.
So that was for physio, and then something similar for podiatry as well.
So we thought the most important thing is what did we do with all of that information? And it's been different things for the two services. So physiotherapy, we've recognised that there's a much greater demand than there is capacity, and we have a capacity problem, and that is now recognised across the system. However, there is no more money in the system, so we've now got to start thinking about how do we then either reduce demand or increase capacity in other novel ways. So we have agreed with commissioning that we'll stop accepting out-of-county referrals. We have agreed with our clinicians that we'll offer them some extra time to do with the triage out of hours, therefore creating more clinic capacity. We're trialling, but it's been really successful, shorter appointment times. So we've had physiotherapists who've been out in primary care doing the new first contact practitioner roles, who are used to doing now 20 minutes appointments instead of 45-minute new patient appointments. So we've been trialling that in core physiotherapy. And we saw 100 patients over 5 days last month. So that's something that we're going to roll out further through shadowing and skills training. We're looking at a skill mix. We're hoping to bring in unqualified staff to do some of the extra work. So these are new and additional roles that we haven't had, so we can skill mix down but create more capacity within the budget that we have. We've moved capacity in some examples. So when we did the subspeciality that was hands, we had too much capacity, so we've been able to move that into core, and so just moving the capacity to where it needs to be. A piece of work that we haven't done yet but plan to is to change our clinical records so that people can record quicker, so we can increase capacity by reducing time spent on record keeping. And a really big thing for us was that in terms of the modelling, it became quite apparent that our assumption of 15 new patients per whole-time equivalent per week, although it was a very strongly held belief, was wrong. And to actually be able to present back to the service, I'll show you a slide later on, that actually you aren't as productive as you think you are, has driven a huge drive, because I think they were quite shocked and have had a good look at themselves and are now actually much more productive than they were 6 months ago, we believe. That's yet to be proven in another round of demand and capacity modelling. So thinking about how all of that worked, there's been a triumvirate really of people, and this has been talked about a couple of times today as well, but we kind of believe this is why it's really worked for us in Gloucestershire, is that obviously there's the service lead involved, we've got a business intelligent lead, and then we also have what we've termed the critical friend. In our case, it was my service improvement role, but it could be anybody outside who can provide that mainly translating role between BI speak and clinician speak. It's a bit like trying to talk to finance, isn't it? I never quite understand, and I need someone to interpret for me. And then you can ask what might seem obvious to us, to the BI or the service improvement team, the kind of humble inquiry questions. We're going to have to speed up because I've had the 5-minute warning. So impact. Do you want to talk about impact rather than me waffling?
Yeah, so from an impact point of view, sort of refreshing some of what we've said already really, the service, we've used modality data to remodel skill and skill mix, shared understanding with our execs and with our commissioners, and I think really it's provided a great deal of assurance to our commissioners that we've got an evidence base to understand what the issues are within our services, but also an evidence base to support some of the changes that we've proposed making and that our exec team have signed off on. And discussions then are underway around some of the resourcing around the gap that we have been able to evidence that we've still got, even with all those changes that we've proposed. I guess the bottom point's really implementation of those changes is underway. We are improving productivity and we are seeing improved performance as a result of some of those changes.
I'll nip past this one, but podiatry essentially wasn't so much that they didn't have enough capacity as it was that they weren't productive enough. So it's been a really hard message, but we've been able to prove it with the data, which is hopefully, we're in the early stages of this, but will lead to increased productivity so that we'll get better outcomes for patients. This was just a slide about the challenging kind of the urban myth, which we've talked about several times today, but the top left is the variation in productivity. So where we were told that people were seeing 15 new patients per day, well, they clearly weren't. Some of them were seeing 1 or 2, and that's adjusted for whole time equivalent, which is fairly shocking and was quite a stark picture to send back to people.
And some of that, just jumping in, when we've explored that with the service, has been around booking processes, it's been around admin processes, it's been around preference from clinicians. There's been a whole raft of issues that we've explored through what's in effect been a deep dive into every aspect of the way the service is delivered.
And then we've also been able to show from the data that sickness and vacancy rates actually hasn't correlated with the changes in performance, so maybe they aren't correlated at all. So to finish up.
Okay, so I guess our learning, understanding the scope at the outset, so that is spending a detailed amount of time up front with the service that you're modelling to understand what it is you actually want to get from the output of the modelling. Testing assumptions, so again back to our number of new patient slots per week, the triumvirate approach. I think the big one is challenging historical beliefs around demand and capacity, so the DNAs, the sickness rates, all those kind of issues that get rolled out first. Service engagement, obviously, but then the modelling is a useful tool to support wider quality improvement. It is not the answer, but it's probably some of the clues and some of the evidence to then take you down that next path.
I think the really exciting thing is when you take services that didn't want to change but are now coming back to you and saying, what next? And they've seen the benefit that this can have.
So, yeah, what next are kind of last steps really. So what we're now looking at is using the aggregation module to remodel our whole MSK pathway. So looking at the MSK physio core element, the MSK element within podiatry, and our musculoskeletal advanced practitioner service to look at remodelling what the service would look like if we pulled all those component parts together. Supporting workforce modelling for the first contact practitioner physiotherapists, remodelling and reviewing the models we've done originally to see what the impact of the changes is that have been made and implemented so far, and obviously rolling out to other services and working with a number of other services at the moment.